Hi. Good morning, Chair Rodriguez, members of the committee, Senator Roth. Thank you for your question. I'm Lisa Schoenthal. I'm the Division Chief for the Emergency Medical Services Authority's Disaster Medical Services Division. Regarding your questions about the mobile field hospital program, we currently have one 200-bed mobile field hospital that EMSA is maintaining without vendor support. As far as a time frame during which we believe we could deploy that hospital and begin treating patients, we estimate, this is untested, but we estimate we could deploy the hospital at this moment within 72 to 96 hours. However, as of July 1st, 2015, this one 200-bed mobile field hospital will join the two other 200-bed mobile field hospitals that are currently stored in delayed deployment status. And these three hospitals at that time will not be considered part of an immediate response effort, and that they would not be maintained in a status that would enable them to rapidly be deployed to treat patients.
Where are they? Where's the one located that apparently is?
One is located at the EMS Authority's Response Station 1 in the Sacramento region.
Are the other two located up here as well?
The other two are also located in donated storage in the Sacramento region.
Is there any discussion, has there been any discussion with other sections of administration on how to keep these at least in some sort of a warm storage condition so the pharmaceuticals are up to date, the equipment certifications are up to date so we could actually use them?
We have had ongoing discussions since 2011, and we have been able to maintain the program until this time. In very creative ways, with public-private partnerships, with supplemental funds. We were able to identify miscellaneous funds here and there. But at this time, today, I am not able to offer a plan that would enable us to keep these hospitals.
Has there been a cost? We're good at costing things, or not so good at costing things around here. Has there been a cost determined to keep these hospitals in some sort of usable state, the three?
At the time when the funding was eliminated from the state budget, the annual cost for the program was $1.7 million. And this involved keeping the three hospitals geographically located in three different locations throughout California.
So for $1.7 million, we could keep all three hospitals in some condition so they could be deployed within hopefully 72 to 90-something hours. That
was the general estimate, yes.
Wow. You know, if they're in storage, if they're in deep storage and the equipment's out of date, the certifications are not up to speed, and the pharmaceuticals are gone, we might as well sell them and return some money to the general fund. Thank you, Mr. Chair.
Well,
Senator Jackson?
Yes.
We have Senator Pan as well after.
On that note, each of these hospitals would serve how many people, 200 each?
They're 200-bed hospitals with a 20-bed emergency department and a 2-bed OR suite.
So,
operating room suite.
You know, the budget is no longer quite as meager. Is there any effort being made? I mean, it sounds like everyone's sort of resigned to this, and frankly, it seems to me like an incredible waste of resources to have these things sitting inactive, and unusable. I think it would behoove us, especially if there is an emergency and there are 200 people who die because we don't have a facility like this available. Is there any effort being made rather than to be resigned to what was a circumstance granted 3 or 4 years ago? But now we're talking about potentially saving lives and having facilities that exist. I mean, to sort of be passive about it is somewhat unsettling to me. So if you could tell us, has any effort been made to put these back on track? The fact they're all in Sacramento isn't going to be much of a kind of a placating factor to the people of Los Angeles or my community in Ventura and Santa Barbara or the people in San Diego. I mean, this is, I won't say ludicrous, but it's kind of bordering on what in the heck are we doing? So could you tell us what efforts are being made to try to reinstate these facilities? You know, we never know when that next disaster is going to occur, but if these things have been mothballed, there are going to be a lot of questions asked.
Certainly. Excuse me. Thank you very much for your question, Senator Jackson. We have never stopped pursuing all avenues to maintain the hospital program.
So what are you doing now?
One of the avenues we're pursuing at this moment is partnering with other states in the Western region, the FEMA's Western region, seeing if other states may be willing. We're doing this in partnership with our partners at the California Governor's Office of Emergency Services to see if other states may be willing to partner with us. This was an avenue that we have attempted in the past among many, many other avenues with the Gulf Coast states because they're very hurricane prone. We thought perhaps this might be something that...
No, I want to keep them here.
Sure.
So what is being done? Has there been a request made in the budget this year? I mean, this is the first that I think some of us are hearing about this. We're talking about a $1.7, maybe $2 million to maintain these and perhaps bring two of them down to the place where 2/3 of the population of California live. I mean, what are you doing? Or what is being done, I should say, not you personally, but what is being done? Or should we not worry about salvaging these? Are they not necessary? Are they not effective, cost effective, should there be an emergency?
Well, we have had to take a very tough look at our priorities, and there actually is a budget request as part of the governor's budget. There is a budget request that would augment the Emergency Medical Services Authority's budget by $500,000. This would stabilize our California Medical Assistance Team program. Currently, and when I share the testimony with you in a bit, and you will see with the written testimony before you that we have a gap in our California Medical Assistance Team program. And we believe it is a very credible step in increasing our current preparedness to stabilize the California Medical Assistance Team program, or CalMAP program as it's called. We have prioritized this above the mobile field hospital program at this time in consideration of the state's budget and wanting to be very credible and prudent with the funds that are available.
So what you're saying is this isn't your top priority and that there are others that are more so, and given the budget, which right now is rather flush, you still are not seeking these funds because you've got other priorities. And there was one other part to that from what I heard. I was trying to sort of translate it into what I could understand it to be saying, that this is not as much of a priority, that you haven't made this request, or you have made a request in the budget, but not for anywhere near what this would take. And the last part of that is a question, which is there federal funding available, and what are you doing to try to get that funding?
Our federal funding has been steadily decreased through the years. My partner from the California Department of Public Health, Susan Finelli, done an excellent job at trying to keep that funding as stable as possible, but those federal funds have continued to decrease.
Why is that?
Pardon me?
Why? Is that because of the federal budget, or California is not prioritized high enough?
I can share that it was never the federal government's intention to permanently fund the states with their preparedness grants. The intention, the plan on the part of the federal government was to provide seed money to the states for programs to be developed, and at that time there was an expectation that the states would continue to maintain the developed programs.
And California has actually done pretty well in terms of the federal funding declines in comparison to other states. We lost 14% of our hospital preparedness program funds 2 years ago. Many states lost between 25 and 40% of their funds. So because of our risk in California and our population size, we've done actually pretty well.
Senator Roth, you have a question?
Let me just say this. I did not mean to sound critical of MSA. My short time up here, I think I'm beginning to understand how the budget process works, and I know that the priorities are set on the first floor and not on other floors. So apparently this is not a priority, but it's unfortunate that it's not unlike other things, whether it's public safety, fire, or you don't need it until you need it, and then when you need it, you really need it, and if it's not there, you're really upset. I just think this is something that's going to require some attention, and I am going to, it may be a little late during this budget process to do anything about this, but you can rest assured that next year I'm going to come at this and see if we can't find the money. I assume that mobile hospitals are still, and I'm not a healthcare practitioner, but I assume that mobile hospitals are still relevant in the overall planning, disaster, and emergency planning process, that there's not some new technique that has caused the mobile hospital concept to be out of date. Is that correct? Is that a fair question?
Mobile hospitals are still considered to be relevant, Senator Roth. The state has simply had to look at what is prudent and what is reasonable and what can we afford.
Okay, well, we'll work on the $1.7 million at some point as soon as possible. Thank you, Mr. Chair. Mr. Chair. Madam Vice Chair.
Thank you. And Dr. Pan had a question or a comment.
Thank you. So actually, first of all, I was a little disturbed to hear that both as a pediatrician and as a father that we're short on beds for pediatrics. So I'd be interested in hearing about what we could do about that. I also recognize that half of all children are covered by Medi-Cal, and I don't know if that's affecting our capacity because of the low payment that Medi-Cal pays in terms of trying to build overall infrastructure for in terms of healthcare access. So, I mean, there's both the ongoing treatment, and then there's also building surge, right? And sometimes surge is not recognized as being necessary until the disaster happens. But if you don't build the capacity, you're not going to create a pediatric bed in 24, 36 hours. And even the mobile field hospital, my guess is that you probably don't have a whole bunch of pediatricians on call ready to take care of those kids. So I'd be a little concerned about that. I did want to just ask a little bit about in terms of the infectious disease piece. I know that our response to infection is both state and, it's federal, state, and local. So I guess perhaps Dr. Chavez can address this in terms of, not only the state, but also localities also suffered, made cuts to public health infrastructure during the recession. And you've listed the litany of infectious disease threats that we're facing right now. How does that look in terms of both our state capacity and our local capacity? Because knowing they're tied together, right? Because we depend on counties to be able to do contact tracing and so forth, and then as well as the state. How's our capacity looking in terms of both state and local support and staffing to be able to do all the contact tracing, and if you need to do quarantining and so forth to be able to handle outbreaks?
Yeah, thank you for that question. It's super critical. And in California, as you well said, we rely heavily on local health departments sort of as the frontline personnel to deal with outbreaks. They are really the first responders. We in the state facilitate their work. We provide guidance. We provide technical expertise to them. But in reality, they are the ones that are in the front lines providing the first response. If you were to talk to any of them, they will tell you that over the last 10 years, their capacity has really diminished because of budget concerns. So many local health departments have lost critical staffing in their laboratories, in their disease investigation groups, epidemiologists, and so forth. So I think that they do the best they can in responding, but in reality, I think local health departments do find themselves frequently short of resources. The other thing that I think it's interesting, and I've been in my job for 13, 14 years, and I have to tell you that over the last few years alone, we really have seen what's a new normal. We used to be able to have one crisis at a time, so we were able to always jump to that crisis, put all our resources, and tackle it. Over the last couple of years, we have 2 or 3 or 4 ongoing crises, and so that really puts additional strain on the first responders particularly.
Is the department looking at perhaps doing an assessment of local capacity, or is there aside from each county by county, is there some way to try to get a sense of what the overall picture looks like in the state in terms of both local and state capacity for outbreaks? You said the new normal, if it's 3 or 4 at a time, right. We perhaps need a reassessment of what we need.
Right.
That's something that.
So that's exactly where we're at today. We realize that we have an opportunity with the budget that there may be chance to rebuild. So we are actually working with CCLHO and with HOAC in trying to find just exactly what is the state of capacity and what needs may be there so that we can try to find ways to help them out.
Do you have a sense of when that assessment might be completed by? That we certainly would be interested in hearing about it from in the legislature.
Right. So I think we're hoping to have something done over the next few months and trying to together come to a better consensus on where we are with our needs in a way that we can articulate for the next budget cycle.
Okay, because I think that's helpful not only from the state level but also in our communications to local officials, our partners in the county. The other question I had, since you mentioned the measles outbreak and was expensive, do you have a cost on how much the measles outbreak cost the state of California and our local counties?
Yeah, we are actually working on that as well, but we do have evidence from some of the the counties that were mostly impacted that each individual case, and I think it's important for the community to know that the work of containing something like measles is very involved, and we had one instance alone where one individual with measles walked into a neonatal intensive care unit and exposed 90 individuals, including a very large number of infants and neonates that were very high risk that needed to be treated to prevent measles. And so one single case leads to very, very large public health response. And so for each case that was exposed, cost is in the thousands of dollars. So we are tallying all that so that we can have a figure of what the outbreak cost to the state.
Can you give me a ballpark figure and maybe a more exact figure later on?
Yeah, we can provide something to you on what we have so far.
Okay, that would be. Can you give us a ballpark figure right now?
I don't have it with me, but
Okay.
we can give it to your staff.
What about the pertussis outbreak? How much does that cost the state? We had 2010. You mentioned that you had 14 infants.
Right.
You had many infants die.
Yeah, that one we don't
2010.
have as much of a handle on the cost because it's much more widespread. I think the measles was much more point in time, so we can actually quantify it better. Yeah.
So it'd be good if we didn't have to spend that money, right?
Right. Exactly.
And focus on many others.
Exactly.
Thank you.
Thank you. Senator Bates, you had a
I
question?
just wanted to make a comment. I'm recently off the Orange County Board of Supervisors where we had a couple of these infectious epidemics, and I was very impressed with the manner in which our county responded. And I also served twice on a drill that FEMA put on for our county. So I think it's important as part of the information for us not to think that we're not ready with certain incidents. If we had the San Andreas fault that we're seeing the movie on, I guess nothing can help us at that time. I was watching that and think it just looked like the end of the world. But things are going on in our counties, colleagues, that are very, very up to the minute. So they are spending the money, though limited, wisely, and I think that should be part of this. So it's the glass half full, not that we're facing a disaster and the state has somehow missed its mark. But I do think it's very important as we see our hospital issues continually in front of us, with them having to close and the resources being redeployed because of the Affordable Care Act and the access to health care. All of that comes together as, I think, a vexing problem in the event of something like a surge, because we're having hospitals close generally in the system, and those, in fact, in the county, we have those shown on our emergency response that they're there, and if, by some unfortunate economic circumstance they close, what is going to replace them? So those are the kind of things that at a county level, where the response, the first responders, we need to know where those gaps might occur, and having that coordinated information from our counties, I think, would help all of us to understand, so we could be focused through the state on what is needed for that great population in Southern California, certainly, that may be short because we do have hospital closures down there. So I'd just like to at least put something positive into the conversation this morning, because I was extremely impressed. We had our drills were based on the fact that San Onofre was still operative. How would you evacuate 300,000 people, many children, many seniors, in a very short period of time, and how we redeployed certainly our responders, how we rearranged our transportation network, how the transit system got involved, and everybody was in the room, and we went through a drill as if San Onofre had a meltdown. and it was very impressive how we were able to actually move that many people out of the emergency zone. So good things are happening. More money always helps, and certainly all of us should be focused on bringing that into the conversation during the budget discussions now, but probably not appropriated till next year.
Thank you. If there are no other questions at this point, can we go on to our next witness, please, if we could? Yeah. And I've been asked to ask you to kind of, we're running a little predictably behind, about 5 or 6 minutes at the most. If you could try to focus your testimony during that time frame. Apologies, but we are running behind.
Certainly. Thank you, Senator Jackson. For the record, as you know, I'm Lisa Schoenthal with the Emergency Medical Services Authority, also known as the EMS Authority, or EMSA. The EMS Authority coordinates the state's medical response to disasters in cooperation with the California Governor's Office of Emergency Services, or OES, in accordance with the State Emergency Plan, and very closely in working with our partners at the California Department of Public Health, or CDPH. In keeping with the tenet that all disasters are local, we at the EMS Authority support local jurisdictions in support of disaster response. We're responsible for the prompt delivery of disaster medical resources to local governments, and this may include the responsibility to provide personnel, medical supplies, materials from the unaffected regions of the state to the affected regions, as well as arranging for the evacuation of injured persons to areas that are not impacted by the disaster. California's medical mutual aid system is a component of the public health and medical system that Susan described from CDPH today. And this public health and medical system is a key component for us of California's standardized emergency management system, which I expect our Cal OES partners will talk about today. It is notable that the medical mutual aid system is different from the fire and law mutual aid systems in that the majority of resources are private as opposed to public. The majority of fire and law resources in the fire and law mutual aid systems are public. For example, there's physically 3,600 ambulances in the state, and approximately 74% of those are private. So this provides the foundation for the state's pre-hospital surge capacity. For disaster medical response, EMSA has developed a significant mobile medical assets program, and this is implemented in accordance with the public health and medical system that you've heard described today. It's also described in greater detail in your written testimony. I will discuss the mobile medical assets that EMSA has developed. Briefly, we'll remind you about the processes and organizations of the medical mutual aid system. So from a high level, the Mobile Medical Assets Program is comprised of ambulance strike teams, California medical assistance teams, mission support teams. You've heard about the Mobile Field Hospital Program. We also have disaster healthcare volunteers, and at the local level, we have the Medical Reserve Corps. So ambulance strike teams, we have 41 of these pre-designated around the state, strategically and geographically located. They ensure the rapid availability of emergency medical services transport assets to disaster areas throughout California. These 41 ambulance strike teams have an accompanying disaster medical support unit that serves as the ambulance strike team leader vehicle. This disaster medical support unit really serves as a trauma cache on wheels, providing medical supplies, equipment, caches of supplies for about 3 days of medical resupply. The California medical assistance teams, you have heard me talk about these briefly today. We currently have one deployable team of 40 persons in Northern California, which could be broken out into multiple teams of 5 persons. And there is support for a second team in Southern California in the governor's budget. So these teams are comprised of medical and healthcare professionals accustomed to working in austere disaster medical conditions. We're talking about physicians, nurses, paramedics, pharmacists, etc., who may be deployed by the governor in response to local requests to assist with meeting the medical needs of our population during times of disaster. The size of the CalMAT may be modified to meet the specific medical mission at the time of the incident. EMSA's mission support team provides support and specific logistical functions for field disaster medical resources, such as the CalMATs, the ambulance strike teams, disaster healthcare volunteers, etc. So in addition to providing and arranging for logistical support, the mission support team provides communication, coordination between the state deployed resources and other deployed resources, as well as with the emergency operations centers at the local level and throughout the state. We have discussed the mobile field hospital program today. Something I did not mention is that a mobile field hospital has not yet been deployed for an emergency response. Disaster Healthcare Volunteers is an emergency personnel management system developed to enroll California healthcare professionals with active, unrestricted licenses as volunteers for disaster services. We currently have over 21,000 disaster healthcare volunteers in the Disaster Healthcare Volunteers program. Each county has the ability to activate their disaster healthcare volunteers. The EMS Authority, in partnership with CDPH, manages this program. This is a program that is used very regularly all around the state on a frequent basis. We automatically check the healthcare licenses for 48 different healthcare professions on a nightly basis. And then at the local level, there is the Medical Reserve Corps, and these are community-based local networks of volunteers that serve their local communities. There are about 8,000 Medical Reserve Corps members that comprise the 43 Medical Reserve Corps in the state's Disaster Healthcare Volunteers program. I was asked today to talk about scope of practice that the EMS Authority participates in expanding as an option during times of disaster. In order to further support medical surge, the director of the EMS Authority may expand the optional scope of practice for paramedics. This was done during H1N1 when paramedics in certain jurisdictions were granted the ability to administer immunizations. And EMS's director expands this optional loc of practice in consultation with a committee of local EMS medical directors named by the EMS Medical Directors Association of California. So Susan described our mutual aid system. There's a medical health operational area coordination program at the operational area level. Information and resources travel up from that medical operational area coordination program to the regional disaster medical health coordination program, and we have 6 of those regional disaster medical health coordination programs that correspond with Cal OES's mutual aid regions in the state, and I expect you'll hear more. This is all part of our standardized emergency management system, SEMS process. In accordance with our system, EMSA may take actions that include activating the medical mutual aid system, mobilizing ambulance strike teams, activating the CalMAT, deploying the mission support team, activating disaster healthcare volunteers. We also provide technical support to local jurisdictions in support of their local disaster healthcare volunteers.
If you could wrap it up for us, I apologize.
EMSA works in partnership with our 33 local emergency medical services agencies that have the statutory and regulatory responsibility to coordinate the day-to-day EMS system that surges when there is an incident or disaster. The gaps you've asked me to address today briefly. The CalMAT program currently has a gap in that there is no Southern California CalMAT capability. With the passing of the 2015-16 state budget, $500,000 will be added to the EMS Authority's budget. This will provide for the reestablishment of a Southern California CalMAT. It will also provide for 2 positions that will participate in catastrophic planning, and some of those activities will be jointly with our CDPH partners. Susan mentioned there's a need for a statewide patient movement plan. We are working on this, and you will have greater detail in your written testimony before you. A gap that is notable is that the EMS Authority has not conducted a field exercise of our continuum of medical care, disaster medical care, the ambulance strike teams, the California medical assistance teams, et cetera, since 2013. This is a gap that we propose to address with the assistance of Homeland Security grant funds. We will continue, in closing, to work very closely with the partners who are represented at this table, in addition to our regional and local partners, in making California more prepared as we go forward. Thank you very much.
Thank you. Yes, I was going to ask, it seems, and I'm wondering whether it's just there's an assessment of risk being greater in Northern California than in Southern California, why it is that the Southern California area doesn't have this resource, which is where 2/3 of the population of the state resides, which is where the potential for earthquake, as we understand it, is greater, where we have access to people coming in internationally into our larger cities, even into Disneyland. Just wonder what the reasoning has been that has been so more focused in the Northern California part of the state than in the Southern California part. If you could answer that briefly.
Thank you, Senator Jackson. We do focus on the entire state in our preparedness. If there is a Southern California incident, the Northern California team can deploy to Southern California, to the affected area. Frankly, as a matter of practicality, as our resources have diminished steadily, we are located in Northern California, and so we have been more available to work closely with our volunteers in Northern California.
Yes, Senator Bates, followed by Senator Roth.
With regards to the 41 ambulance strike teams, are those actually ambulances that the state has to send out to, the various areas? And are those located throughout California, or are they concentrated in Northern California?
Thank you, Senator Bates. The 41 ambulance strike teams are comprised of 5 like ambulances. So 5 ambulances staffed with emergency medical technicians that provide basic life support, for example, or 5 ambulances staffed with paramedics that provide advanced life support, in addition to a disaster medical support unit leader vehicle that has common communications and can communicate with these 5 ambulances. They are strategically all over the state. Initially, we placed them based upon having one pre-designated ambulance strike team per 1 million population. But that has not been our strict formula, because we have also looked at geography. In addition to that, for example, up in the northern part of the state, the population is not high, but we wanted to be sure that we had resources there too. So they're very strategically and geographically located.
And do you work with private companies also?
We work in partnership with local EMS agencies, and many of them are placed with local EMS providers, yes.